So, Dr.
Yes, sir.
Nivean, please.
So, respected teachers, senior ophthalmologists, my dear friends. So, I'm going to talk about choosing the right IOL between monofocal, multifocal, EDOF, and trifocal. Can we have the slides up there? Yeah. So, I do not have any financial interest because we have so many types of IOLs and so many companies that are involved in this. But there are certain drivers of good outcomes after cataract surgery. The first key, most important, is safety and efficacy because that is the most important. And as long as the patients are happy, definitely everything goes well. Then the efficiency, I think the previous speakers have spoken about how to get a perfect biometry to do the perfect surgery. So all of us are trained to do that. Then nowadays we all know that cataract surgery is not only giving just 6/6 distance vision, but patient wants 6/6 distance visions. They want N6 near vision. They want intermediate vision. They want good contrast and no glare and halos. So all these terminologies are being known by the patients also thanks to the internet. So and we are also achieving target emmetropia. I think initial days it was about 6/6, but no longer it is just 6/6. All these things put together is only target emmetropia. So how do we choose an IOLs? Like there are 2 points of view, one from the surgeon's point of view and one from the patient's point of view. So we are always focused about the lens material. Yes, hydrophilic, we know the advantages and the disadvantages comparing between the hydrophilic, the hydrophobic, and the surface coated lenses. And the various designs we have, the C loop, we have the plate haptic lenses, the four loop haptic designs, and then the various cost of all these lenses. Procedure wise, I think now the phaco has become a gold standard and the 2.8 incision or the 1.8 incision. So there is a quick and fast recovery because the next day patient wants to see all these things, or sometimes in some hospitals, I know the same day their expectation is to read all the letters and they want to get the other eye done the next day. And we are also worried about the PCO and the spectacle independence. So nowadays, choosing the right IOL requires a complex and objective assessment of various factors. One, we should know about the optical properties of all these lenses and not just go by what is driven by the market, and the visual quality. So there are two key important things here is one is the quantity of the vision and one is the quality of the visions. There is also a new classification according to the patient side. One of the I've just classified this on my own, like the social causes, like how motivated is the patient in getting this IOL. So that is a very important thing. And most of the patients we know come saying that my neighbor has got this or my relative has got this. So they also know about what are the advantages of those things and how happy he feels, and that puts us under pressure. Then the other things like the lifestyle of the patient, what are his do's and don'ts. That is why customization is the key word here, and it is not like one size fits all. So customization is the key for choosing the right IOL, I would stress here, because different models are there, different companies are there, and the other factors as far as our country is concerned is the costs also. So what I meant is that extra chair time is very important. I think all the speakers must have told about this. Just to know when they say reading, hereafter reading what used to be only the books is no longer reading. So if they're reading, then they need to have good near vision. So you should plan that kind of an IOL which gives you a good ad power. But if they're going to read in tablets or their reading is going to be in laptops, then you should think of different group of lenses like the EDOF lenses, which are actually better when they give a range of vision. And then what kind of activities do they play? Are they sports driven persons? Because unless we ask, we will not be able to know. We can't assume things nowadays with the patient. So spending those time and asking them what are the extracurricular activities, is it just reading or they do outside activities like golf or driving. So all these things are very very important. We tell them, but most of the times in our practice, because of a busy practice, we did not ask these questions. And later on when the patient says, doctor, I'm doing this, I'm not able to focus when I play badminton, so that is when we are hit actually. So we have all the different types of IOL options. So we all know that monofocal is only going to cover the distance vision, and multifocals are very good in covering the distance vision and the near vision. So always there used to be this fine line between trifocals and EDOF when I started off. So I keep it very simple. So trifocals have all the three zones. So they cover distance, intermediate, and near. So EDOF is very good for distance and intermediate because that is where the range of vision comes. But there's a slight compromise of the near vision. But most of the EDOF lenses, people say we usually give a myopic shift so that bilaterally they are happy with the vision. So as I said, between multifocals and trifocals, and how the different types of lenses work. So we did our own study just to explain in a nutshell to first year. So we chose four different types of IOL. So monofocal IOL, multifocal IOL, EDOF lens, and a trifocal lens. So we chose four different IOLs and subjected 30 patients in our study to understand. Even though we know the properties, In our hospital, we have this, anytime a new lens is introduced, we always take it up a challenge that we do a study on those lenses about the patient for us to understand as doctors how the particular lens work. Is it giving the same results as what is told by the company? Only then that it increases our confidence, and then once we are confident, we know when is the right patient that deserves the IOL. So the multifocal, we chose the accretive IOL. As you can see, most of these multifocal lenses have lots of rings and they're closely packed. And because of the sharp edges is why they had more glare and halos. And then came the group of trifocal lenses where you have both the plate haptic design and the loop design. So basically, because of the spacing of the rings, it gives you all the three ranges of the vision, and they have this apodization. That is, those sharp edges have been rounded off. So the internal reflection of the light that happens in these multifocals are lesser. And because of that, the loss of light energy is lesser in these trifocals. That is why you're getting all three ranges of vision with lesser glare and halos. It will never say that no glare, because any lens that has rings will have some amount of glare and halos. It is just that we use the word lesser glare and halos as compared to multifocals. And this was a study which we did 2 years back. So that time we were doing it with in-focus IOL. Nowadays, I think all the companies have come with various different types of EDOF lenses, but they all work on the basic principle of inducing positive spherical aberration on the surface of the lenses that elongates the range of vision. So here again, at that time we had this in-focus lens which has got that central zone which helps in giving the near vision add. So this is the newer, the Rainer extended monovision lenses. As you said, these EDOF lenses, you don't have those rings. It works on the basic principle of the inducing positive spherical aberration on the anterior surface of the lenses. And most of these lenses are all fully preloaded lenses. So they also call it as a no-touch technique, where you don't have to remove the lens from the cartridge and place it inside. And you see here, you can't see the rings. So going on to the results, ours was a 1 year follow-up period about comparing all these lenses. So the exclusion criteria was the same for any of the trifocal lenses, like any retinal pathology, glaucoma pathologies were not included in this particular study. But what I like to emphasize is the EDOF lenses are very forgiving lenses. So I would say that is more like a glorified monofocal lenses, where even if you have a retina pathology or a glaucoma pathology, there is no drop in any contrast or anything when you use the EDOF lenses. So in our study, if you can see, as far as the distant visual acuity is concerned, all the lenses gave good visual acuity. So all four lenses are good for distance vision. But when it comes to the defocus curve, you can see that unifocals work only for distance, and the orange line has two peaks. The multifocals always two peaks, and you have an intermittent gray area. And then the trifocal, you can see the gray line which has three peaks here, and the EDOF lenses which has a range of vision. So as far as the contrast, yes, it is very evident that monofocals and EDOF lenses have the best contrast sensitivity, as there is no rings. It is almost as normal as what our normal lens is. And multifocals was the least, and trifocals were far better because of the reasons as I told you, because of the sizing and the shaping of the rings that are there in the lenses. So the spectacle independency was the maximum for trifocal lenses and EDOF lenses as compared to the multifocals and monofocals. So in conclusion, it is good to know about all the ranges of lenses, and actually we should titrate it to what the patient wants. So what the patient's needs are. So then we have to explain it to the patient how it's going to work. And also in any of these lenses, we always tell that it is only 98% chance. There is always this 2% or 1% chance that you might be requiring glasses for doing your work. And that has actually helped us a long way. So considering the surgeon's experience with IOL technology would be better than just going with the manufacturer's marketing strategies. So no single multifocal IOL or EDOF lens will suit all patients' needs. So we need to have a holistic approach in this particular thing. So once again, like to thank AOS and Balla sir for giving me this wonderful opportunity. Thank you, sir.